Thank you very much. So what I would like to do is just start off with a little bit of a quick overview into what we can expect in today's presentation. So I'd like to start off with an introduction to GMB Health Systems and just really discuss what our involvement is in the open HIE community. I would then also like to provide a short story about who I am, how I got started with FHIR, and the path I took towards becoming FHIR proficient. Then we'll have a brief overview of the projects I'm currently supporting, followed by a more detailed look into what is happening in Ethiopia and Sri Lanka. And then we will reflect on some of my experiences and identify opportunities coming from the World Health Organization conference that I attended in Rwanda during the month of October in 2023. Then we'll have a look at lessons learned, followed by the common FHIR implementation challenges that I've experienced over the last 1.5 years of my FHIR career. And then lastly, we'll have a brief overview into the standards and interoperability with special emphasis on FHIR as a standard in HIE. So just a quick introduction. So GMB Health Systems is a Centers for Disease Control and Prevention technical assistance platform partner whose current focus is to work in collaboration with TAP cooperative agreement partners, including PATH and UCSF and CDC country officers to provide FHIR training and capacity building to promote standards-based data exchange in health information exchange. TAP is a CDC funding mechanism that enables global health information systems experts to help strengthen health informatics in countries according to the Informatics Savvy Healthcare Organization approach, including HIE through standards and interoperability via collaborative development, implementation, and technical assistance. GMB is an avid supporter of FHIR and continues to contribute to the open HIE community through coordinated HIE strengthening activities. So just taking a little bit of a closer look into who I am. So as you've heard, I'm GMB's lead systems analyst. I come from the tertiary education sector in South Africa. I've been with them for almost 9 years, maybe slightly more, where my primary focus was on systems development, more on a technical systems analyst role with heavy focus on development. I also have 7 years business and systems analysis experience coming from the public health sector in South Africa. And I'm a member of TAP by acting as one of the lead FHIR experts focusing on the incorporation and appropriate use of standards in health information exchange to promote exchange compliance among disparate information systems. And I became a member of TAP back in, I would say, if I recall correctly, November of 2022. That's when I became an active a member of TAP, and then moving my way towards the FHIR capacity building capacity to drive FHIR initiatives that are funded under TAP, specifically with regards to training and upskilling, and lately moving towards assisting countries to shift towards implementation as they kind of transition from upskilling in FHIR, but actually make use of the skills and implement it in country as they become ready for the FHIR use cases. So what is my involvement with FHIR? As GMB's FHIR expert, I'll contribute to the FHIR community in the following ways. So I would navigate and understand the business use case described through clinical data definitions, typically through data dictionaries. So what does that really mean? So as we start thinking about FHIR, where do you start? This is one of the key things I tend to always put a lot of emphasis on with countries, ministries, directorates, analysts, and so forth. You need to understand your use case, and your use cases are typically defined through data dictionaries. You need to understand what your exchange is going to be working with. You need to describe this very, very well. Then you're going to take that and think about how you're going to translate the clinical data need into a computable compliance framework. And that's typically through the use of a FHIR implementations guide. And then what I'll also do is support FHIR capacity building initiatives through the guidance of GMB's program management team, and in many cases through TAP's funding mechanism. And capacity building in the context of FHIR specifically sees my involvement in the following ways. I'm a lead FHIR trainer. So what that really means is we've created, which we will see a little bit later, 2 very specific FHIR curriculums. One that really talks to how to understand your minimum data set and actually map that to FHIR resources. And then again, how do you develop? What is the process it takes to develop a FHIR implementations guide, right? That can be very, very technical. So as a lead FHIR trainer, I'm responsible for, together with my team, which we'll describe a little bit later, to define these curriculums, and actually execute these curriculums to very specific and strategic training programs in country to help create capacity. And then I'm also a key consultant providing implementation guidance and support. So what that really means is, as we start thinking about the architecture, the various systems, your EMRs, your lab systems, dispensary imaging systems, your different registries, while we start thinking about how these systems are going to work through interoperable mechanisms, what are the standards that need to be implemented? What is it going to take? What does FHIR need to do? How does the exchange need to support FHIR? Or maybe I should actually rephrase that. What does FHIR need to do to support that exchange requirements? So we start thinking about that from an HIE perspective, and also advise on technical architecture supporting the implementation of FHIR. So where did this actually all started? So I started with FHIR in October 2022, where my first task was to develop a FHIR implementations guide for HIV case-based surveillance. Naturally, of course, with no experience at all, this was a very overwhelming task. But shortly thereafter, I built the COVID-19 case reporting FHIR IG. Both IGs were funded under the TAP mechanisms, and the process involved the creation of a minimum data set per use case, where each data element in the minimum data set was first mapped to the appropriate FHIR resource. Once this minimum data set was described per use case, did I take that information and then actually really understand what it is that I need to create when it comes to the profiling activities in the FHIR implementations guide. Something, I don't know who all will be involved with the FHIR IG authoring process, but one will quickly understand that when you create the minimum data set, that is the use case, the data requirements that will need to take place from one system to another. Basically, it's your data exchange and compliance requirements. A data analyst, not a data analyst, sorry, a business analyst is not going to map each and every other data element that the resource expects. What that means is like elements that are mandatory. For example, this very specific values that might come with a particular data element in a resource. That is not the requirement of a minimum data set. That's not the responsibility of an analyst. That is their requirements. So what I'm trying to say is, you'll always find that even when there's an ask for the requirements through a data dictionary, you will still have to go over and above and think about what else is actually required to be compliant with the base FHIR resource. And if something is missing, it is the FHIR IG author's responsibility to take back, especially if there's something they don't understand and they can't go and constrain something specifically. Follow up with the business analyst, who follow up with the analyst team, maybe the in-country representatives who's leading the creation of these minimum data sets. Find out from them what is appropriate and what's not. By August 2023, I delivered TAP's first two FHIR training curriculums together with my team. And those two I mentioned a little bit earlier, but it is the Essentials for Profiling curriculum, which is essentially then the taking of the minimum data set and mapping that to the FHIR resources and the appropriate data elements. And then the other curriculum would be the Essentials and Implementations Guide training. Now, what I would like to point out, I've got a few links to very useful resources in the notes section of all these slides. So what I will do post at this webinar, I will happily share this presentation with everyone so they can actually have a look at these resources and also have a look at our training curriculums. And using the first version of the curriculum, which is FHIR Essentials and Implementations Guide training, I conducted my very first and successful FHIR training to the Addis Ababa City Administration Health Bureau in Ethiopia, the informatics team, where GEMBI is collating ART treatment data from more than 50 facilities into a central data repository using a health information exchange with FHIR messages and a shared health record. I've since conducted several virtual and in-person trainings using two training curriculums that we saw a little bit earlier. FHIR quickly became one of my greatest passions, but I knew that I had a lot of research and learning ahead of me. And then, of course, I took the FHIR certification. It took me quite some time to lead up to this FHIR certification. I would say it took me I was very involved with FHIR for about 8 months, which was wonderful through GEMBI and, of course, through the TAP funding mechanism. I had the opportunity to actually get down and my fingers into the grips of developing FHIR implementations guides, creating the profiles. I was actually a bit in the deep end and actually referring to consulting the FHIR community through chat.phir.org to really ask questions and see some of the questions that had been asked before, doing several online reading, going through articles, which there aren't that many of, looking at FHIR shorthand through the MITRE Corporation, and really understanding FHIR shorthand as a tool, which is just one such tool, and how to create your FHIR implementation guide. So there was a lot of months that actually led up to the point where, and of course through my trainings together with my team, to become comfortable and say, I'm actually ready to start actually thinking about doing the FHIR certification examination. But as I prepped for this, I attended the FHIR training by the Standards and Interoperability Lab Thailand, which was in August, well, between July and August in 2023, which was highly informative content, well packaged, and recommend for those individuals moving towards an expert level FHIR competency. I must personally say that when I saw the content and how it was delivered and the structure, I was absolutely amazed, and I found it so helpful, because it really did help me. And I must say also it helped me think about some of my training curriculums and some of the content that we've put together in our presentations as well. There was a lot of key things that stood out to me in that training curriculum, which I then borrowed and actually used in terms of guidance, especially like with the API, how to execute the gets and the various, the rev include, the includes, and how to use the references. There were just so much resources around security, which actually really pushed me in another direction, which was extremely helpful. And also, if I had to also reflect, I would probably say ideally, just because of my experience, I would say individuals should have around 3 months industry exposure in really trying to get into a well-tailored training as such to really move towards expert FHIR competency. Because I think it's just in general, I think as we all know, FHIR can be quite technical. It's quite a lot to take in. It does take a few months, in my personal opinion, to really get to the point of really understanding FHIR. So then I took the HL7 FHIR R4 proficiency exam in November 2023. And I must tell you offhand, it is not an easy examination. Just to read through, so I don't know if I'm allowed to really get into the details of the FHIR certification. I know there's some very strict clauses around that, so I won't go to what resources to read and whatnot. But what I can say is that it took me about 2 weeks just to read through the articles and the resources that the HL7 provide me in terms of examination guidance. And what I would like to put special emphasis on is that this is not just about understanding FHIR. What is a resource? What data element to use? It's bigger than that. It's about thinking clinical. What is the business need? You need to understand what is the business need, which is, when I say business, I'm talking about clinical in this case. What is the appropriate use for those FHIR resources? And we'll see a little bit later with some of the common challenges that I've identified. I've seen instances where implementers could be just in a staging environment. I can't really say I've seen anything in production really, but they've implemented something in FHIR, but just because they've implemented something in FHIR and FHIR is accepting those messages doesn't make it appropriate. You could be using the wrong resources to capture the wrong data element. What happens when you scale out and later on there's other interoperable systems that want to start using the same enterprise architecture? You're not going to have apples talking with apples. You're going to start having problems. You're going to have data being stored at different places in your FHIR server. That can be a huge problem, especially when it comes to reporting. But we'll talk to some of those challenges a little bit later. So I'm actually in the process of compiling a portfolio of evidence, describing my FHIR expertise with regards to FHIR trainings and project engagements, so that I can become a certified FHIR educator in GEMBI and TAP's FHIR community. So I've actually applied for this back in, I think it was December or January this year. I just haven't had too much time to put together a portfolio of evidence. Fortunately, I've had a reminder coming from HL7 yesterday, asking me to, just to kind of put some haste onto my application so I can move ahead with this. But that's one of the next phases for me, taking, well, should I say, moving forward from my my HL7 FHIR examination. And then key persons from CDC coordinating the overall delivery and strategy for FHIR capacity building within TAP are also supporting this next phase of my skills development within the TAP FHIR mechanism, as well as within GEMBI. And just to note, there are also only a handful of certified educators. Stand corrected, I think there's about 4 to 6 the last time I looked, which was about 2 or 3 months ago. So I don't know how many there are now, if that number's actually increased or not. Just some current FHIR work and projects that I'm currently looking at the moment. So we're looking at the adoption of FHIR in Sri Lanka, specifically with regards to the international patient summary, but we'll see that a little bit later. We'll talk about that. I've got some slides for that. And of course, the adoption of FHIR in Zambia. So we've recently done a technical training. What that means is understanding a minimum data set, as I described earlier, create your FHIR implementations guide through the profiling activities derived from your minimum data set data definitions. And now they're thinking about moving to, or they're not thinking, sorry, they're planning to move towards the implementation of their health information exchange with regards to FHIR. And the specific use case in that area would be immunizations for now as a starting point. But through the shared health record, there will be opportunities to start thinking about the lab data to also be made accessible for secondary data use and data sharing for longitudinal clinical records and continuity of care. And then, of course, the adoption of FHIR in Botswana. So we've recently engaged with Botswana. So the use case at the moment is also being focused on the international patient summary. There's also been some discussions around the various types of how do you define an international patient summary? Now, first of all, international patient summary means cross-border, correct? But it doesn't have to be cross-border. It can be within the country's administrative boundaries. So that's one of the key topics we also spoke about in Botswana, but also how do you define a patient summary tailored to a specific service, tailored to a specific audience? So that's one of the things we discussed while we were there. And there were about 5 use cases that came out of that, just really understanding the uses for the patient summary. And then we're moving towards FHIR training in Kenya that hasn't been initiated yet, but it will be initiated soon. And we're also busy supporting some ongoing training, FHIR training in Uganda at the moment. So they've defined their use case as patient referrals. So we've done some introductory trainings with them, I think about the last 3 months of last year. And now they're getting more specific. Now they've defined a very specific use case, like as I mentioned, which is patient referrals. And we're helping them actually define the minimum data set, map that to FHIR resources and data elements. And then, of course, start thinking about the FHIR IG profiling activities. And just a quick look at my team. So as you've heard, myself, I'm the lead systems analyst and FHIR trainer. I've also got Kanti Madishana, who's a systems analyst and FHIR trainer in my team. So we are the 2 key persons essentially representing GEMBI. We both started with FHIR at exactly the same time, and it's been a remarkable and exciting journey. So Kanti is like my right-hand man when it comes to FHIR, supporting a lot of the FHIR training activities, the development of the training materials, supporting the technical trainings in country, which is really, really great. We're also in the process of hiring a senior systems analyst. I've just started that process off. I'm not quite sure when that will be in full effect, but hopefully in the next month or 2 or so. And then just a quick look at our partners. So we've got Dr. Joshua Kaluba, who's a medical doctor and subject matter expert employed by Symbionics. So he's supporting my team through like terminologies, just general SME expertise as we start thinking about use cases at appropriacy from the clinical business kind of translation going towards the technical need. We have ICAP Ethiopia supporting the implementation of the central data repository that we'll be talking about a little bit later in Ethiopia. Then we've got CDC. They coordinate the FHIR capacity building requirements in TAP-funded countries. And then we have PATH and UCSF, who both support the various FHIR capacity building and implementation tasks, which are governed and identified and governed by CDC. But just a quick look at some of the use cases I was talking about a little bit earlier. So this is the architecture. I don't know if it's very visible, but like I said, the presentation will be shared, just to look a little bit closer. But this is the HIV central data repository. And just a quick reflection on the current status. The system has been implemented in Ethiopia, the Addis Ababa Center for Centers for Administration Health Bureau data center, and is currently connected with EMR systems, specifically SmartCare, in 50 facilities and are in the process of scaling up. The current implementation is reportedly stable and performant. The CDR comes with 31 reports tailored to support patient-level line listing reports, as well as provide regional level, which later will also include national level aggregated reporting. The CDR aggregated reports enable evidence-based decision-making. The data management and HIV program team are using the CDR reports for HIV program monitoring, where relevant feedback is provided to health facilities. And of course, there were some comparisons of the site data with data stored in the CDR, which has been recently indicated that there's a coordinates of 99.9%. And ICAP plans to implement, all sites, or to reach more sites with a VPN access. And the sites that we're looking at is around 100 sites, which is quite a big scale up. The next phase, which is starting in 2024, is to implement a national data repository as the country prepares for the shift towards national level continuity of care. And then just to reflect a little bit on some of the metrics. So the number of, as we saw, the number of health facilities integrated with the CDR are 50 and are very quickly scaling up. The total number of reports currently implemented are 31, which is basically consisting of line listing and aggregated reportings, almost at about 50% ratio. The number of transactions processed by the central data repository for the last year is almost 6 million. The total number of patients is almost 54,000. The rounds of data quality checks have been 4. And as we've just seen, the data quality check has a 99.9% accordance, well, basically accuracy data gap. Then the international patient summary in Sri Lanka. So the international patient summary for Sri Lanka is still in the early implementation phase. The IPS in the context of the Health Information Exchange can be described as a FHIR implementations card, which is a computable compliance framework for a specific use case that is to provide cross-border patient summaries to registered clinicians in participating countries. The base FHIR implementations guide provides the foundation to be adopted, which can then be further adapted to meet the needs of the implementing country. That's exactly what we've done for Sri Lanka. So, but the international patient summary, like with any FHIR implementations guide, provides the basis, it provides the foundation from which you can actually derive your very specific use case. So what that really means is you can actually make use of the international patient summary and tailor it. You can further constrain if required. You can add additional profiles to the international patient summary. And the same applies to any FHIR implementations guide in general. And that's what we did for Sri Lanka. So Sri Lanka also implements an open concept lab mapping mediator. And currently there's no OCL support for direct FHIR terminology validation. That's why we're using this mediator to support the exchange. So what that really means is when you start thinking about your validation service, which comes with FHIR, in other words, when you send a message to the FHIR server from your EMR, could be from a lab or from whatever other systems initiating that request. When the FHIR server receives a code, the FHIR server is supposed to then take that code, talk to some API, and this API is actually exposed by a specific code system. In this case, for example, like a SNOMED or a LOINC to an ICD, RxNorm, or plenty others. And then the intent is then to take this code, make sure the code exists in that code system, make sure that if there's a display name passed, that the display name also is appropriate for that particular code, and then actually get a response back and then say, right, yes, I'm happy with this code. Let's continue with the rest of the validation of this message. Now with OCL, and this was also through some conversations I had with Region 3 for about 4 weeks ago, that kind of automation process between the FHIR IGIN and OCL as a FHIR service doesn't yet exist. So we needed a way to allow, well, should I say, we needed a mechanism that will be able to talk to OCL and then actually get the specific codes. And when a code is received from the exchange, take that code, use that code through a lookup, which has been fetched from OCL, which is now localized in the mapping mediator's response, and say, right, this code A is actually now going to be code B, and then pass code B, or should I say, put code B back into the message and then send that message to the FHIR server. So without getting too technical, that's just a bit of a high-level workflow around the purpose of the mapping mediator. But we really are hoping that they will have, that we will see that kind of support for active and almost, close to real-time implementations guide validation happening soon. That'll be really, really fantastic. And as I mentioned, the links in my speaker notes, the notes, sorry, in my speaker notes do have links. So please feel free to also navigate to the Sri Lanka IG and other resources just to really understand what I'm talking about. In order to make use of the IPS FHIR IG specification, there's just a few things you need to think about. You create a use case specific IG, which includes the IPS FHIR IG package information as a dependency. Right, what that really means is in your configuration of your IG, you need to add the package as a dependency, like with any other IG that you want to make use of when it comes to creating your own IG. Then you also need to install the IPS FHIR package to your FHIR server. And if you don't do that, the FHIR server validator would fail any sort of validation against the IPS structure definitions. And then IPS also comes with a $summary endpoint. So what that means is, while it comes standard with FHIR, it's not enabled by default. Sorry, just to make that clear. And it is used in GET requests to display the patient information in the desired summary format. So what's quite nice about this way this endpoint's been defined is that you can profile as many different patient summaries as you want. This is what I was talking about with Botswana. There are 5, at least for now, 5 different versions of the IPS summary to capture the needs. That means that when we create this, we can have the summary endpoint basically be used for one, at least up to 5 specific summary outputs. And you can have as many as you want. That's actually quite useful. Some future opportunities. They're just looking at some learnings from the WHO conference in Rwanda. I attended the WHO Rwanda conference titled Interoperability Hackathon for Digital Health Transformation in the African Region, Immunization and Disease Surveillance, and that was in October 2023. The focus was on the WHO Smart Guidelines for Immunizations. A key learning outcome for me was the ability, well, should I say, is the ability to leverage FHIR resources describing questionnaires, questionnaire responses, activity definitions, plan definitions, concept maps, structure maps, logical models, measures, and libraries to inform interoperability among devices using decision logic. And that is, of course, closely coupled with clinical quality language, otherwise referred to as CQL. And while that is still a rather new domain for me, I'm aiming to explore this area to great technical depth and hoping to achieve this, really get into the details of this by December 2024. And then just a quick look at what are the WHO Smart Guidelines. I won't go into too much detail about this, but just for those who's kind of seeing this for the first time. So the Smart Guidelines, otherwise referred to as standards-based, machine-readable, adaptive, requirements-based, and testable, are comprehensive set of reusable digital health components. In other words, interoperability standards, code libraries, algorithms, technical and operational specifications that transform the guideline adaptation and implementation process to preserve fidelity and accelerate uptake. And the Smart Guidelines provide a 5-step pathway to advance the adoption of best clinical and data practices, even if a country is not yet fully digital. So like with any other FHIR implementations guide, a country can actually adopt the WHO Smart Guideline and they can actually adapt it. If there's something inside there that where a country might say, this is actually very useful, but doesn't capture my use case fully, you can actually adapt it. This goes through to the profiling activities, add what you need to add. If there's something that you can remove, maybe the Smart Guideline has said, this is not actually a requirement. It's there, you can use it, but it's not a requirement. And if you don't need that in a profile, you can actually remove it to just kind of avoid confusion when it comes to implementation. So you can really tailor your Smart Guideline to support your country's needs. So there are a couple of layers. There are 5 layers. I won't go to too much detail. So layer 1 is just really the narrative. It could be like, I don't know, Google Documents, Excel spreadsheets, Word documents. It could be a note in your table. It could be a drawing from Noteboard. It's just really describing your narrative. What is this guideline actually going to look like? What is it going to take to put this together? How do you describe this? Then you've got your operational side of things, which is the digital adaptation kits, which is the more streamlined, validated, reviewed, digital copy of what your requirements are, describing your smart guideline requirements. And then you have your layer 3, which is machine readable. So this is where your FHIR implementations guide, your FHIR architecture comes into place. Your FHIR IG will then be able to have FHIR resources defined through profiling activities that meets the needs for the digital adaptation kits, in other words, your data dictionaries. Executable is simply the software, which is essentially your health information exchange that's going to be executing these various messages in your exchange and using your FHIR implementations guide, or adopting it, should I say. And then dynamic is just simply then reporting, just to kind of offer a very high level. And then some key lessons learned. So while there are FHIR trainings available to help an individual get started with FHIR, in my opinion, a FHIR enthusiast will require months of research, continuous engagement with the FHIR community for support, FHIR IG profiling experience guided by several real-world use cases, and of course, provide FHIR implementation support. It took me almost 1.5 years to feel comfortable and confident with the FHIR trainings and health information exchange strengthening activities through FHIR IG development and health information exchange consulting. That's specifically through standards-based compliance. In my opinion, the adoption of FHIR can be very technical, this requiring the skills of experienced individuals such as technical analysts, business analysts, terminologists, and subject matter experts. So just a quick reflection. I mean, this is not a specific definition that I've put together. This is just something I kind of thought about, which just kind of seems to resonate with how I've really seen the various kind of participants and roles taking part when it comes to defining your FHIR exchange and authoring your IGs. So the way I see a technical analyst is responsible for creating the HTML web pages for data models, use case diagrams, technical diagramming, describing testing strategies, in other words, your conceptual framework and maybe even your testing harness, sequence diagrams, and other technical artifacts which help articulate the purpose of the FHIR IG. This is, of course, all information that will then be included into your FHIR implementations guide. And also just to note, some of these artifacts are led by the business analyst, but will require the assistance of the technical analysts to use appropriate modeling and diagramming techniques to display the content in the published FHIR IG web pages. And then for me, a business analyst should be responsible for documenting the minimum data set containing the FHIR mappings which will be used during FHIR IG profiling activities, motivating the business need by defining a business description, functional requirements, use cases, and reporting objectives, just to name a few, and then documenting the terminologies and vocabularies for specific data elements in the minimum data set. And just another note, it is recommended that the business analyst works closely with a terminologist and/or subject matter expert. And then, excuse me, then just a quick look at the roles of the role for a terminologist and a subject matter expert. So terminologists are essentially specialists in the health context who ensure accuracy, appropriateness, and consistency of codings that are used to represent clinical procedures and findings. And an SME is a specialist who are well informed in a given health domain and are able to provide guidance through leadership to ensure the decisions are made, to ensure decisions made are appropriate for the focus area. And SMEs are also likely to work closely with terminologists and the business analysts. Then some of the common implementation challenges. So translating the business clinical need to technical artifacts. This is probably one of the easiest and unintentional mistakes, which will be then, of course, the inappropriate use of FHIR resources. And just to name some examples that I've encountered in my career this far, these are just examples of plenty others, but just listing some out. Capturing your ART follow-up data in an encounter resource, capturing an ART status in the medication dispense resource, capturing the next visit date for an ARV regimen pickup in an extension in the care plan resource that is not nested or not found where it should be, and that is in the care plan.activity.detail, because it's a very specific visit associated with your ART treatment and care program. And then another one would be an absence FHIR implementations guide. So in several instances, I've seen some FHIR-aware architectures where there are some exchanges taking place, and some could, like I said, not necessarily production, but it's pretty large, or a lot of amount of effort has been put into creating like this architecture, but there's no FHIR implementations guide. So many implementations make use of FHIR without the governance of a FHIR IG, typically by developers. In my experience, this is largely attributed to the limited understanding of the role for a FHIR implementations guide to describe a particular set of use cases through FHIR profiling activities. Then this is where the pain really comes in. Reverse engineering the process for creating a FHIR IG can be tedious and likely will identify use case non-compliance and in many cases inappropriate use of FHIR resources. And I have seen this already. So while your FHIR implementation, you have a payload and your messages are being sent to the FHIR server. And because you're satisfying the needs of the base FHIR resource, but there's no implementations card, FHIR will not complain. If you're providing a code from a specific value set where it says you must provide a code and you are providing that, it's not going to complain. If you're providing a value for a mandatory data element and you're satisfying the data type, it's not going to complain. But what you're sending, is it actually appropriate? Are you sending data in the right places? That's what you need to really think about. The levels of appropriacy as you transition from clinical to technical. So to reverse engineer a payload into a FHIR implementations guide can be extremely difficult. And yeah, might require quite a bit of upfront investment to fix that. Then just some acknowledgements. So GEMI's work on FHIR is funded by the President's Emergency Plan for AIDS Relief, otherwise referred to as PEPFAR, through the CDC Technical Assistance Platform Program and a generous grant to GEMI from the Patrick J. McGovern Foundation. I would like to just quickly pause there for a minute. I see we are at 44 minutes. I think this was my quota. I would like to have gone through some slides that just kind of offers a bit of an overview in standards interoperability, but I'm just a bit concerned about the time. So perhaps I should pause there and then maybe the participants can actually read through this if they want to. It's a very short introduction. I'll just kind of skim through it, just around the importance of interoperability and why we need it. And we start thinking about the different systems that participate in your health information exchange in your HIE ecosystem. And what does it take to become fully interoperable when you start thinking about standards? So this will also just talk a little bit more about the different levels of interoperability. You got your foundational, structural, semantic, and organizational. So the foundational is basically saying, have your architecture established in such a way that a message can be sent from one system to another, and the other system can receive it and send a response back. It doesn't matter whether the system can actually interpret the message. You must just be able to receive it and send a response. Structural, you start thinking about your syntax, the format of your message. Is it XML? Is it JSON? Then semantics. Let's add more meaning to this message through codings. In other words, you start thinking about systems like imagine you've got a message being sent from an EMR system to a lab system. While there's one specific code that's really accepted and, how can I say, recognized, but suddenly there's a whole bunch of other codes coming in. The system's not going to be able to report on those other codes because it doesn't know what to do with those codes. There's no standardization now. So through codings, you add very specific meaning to very specific pieces of data or portions of data. And organizational, this for me is one of the most challenging parts and gaps I've seen so far with some country engagements. Your governance. What are your data sharing policies, your security policies? For secondary use, for example, retention. Do you have user consent? There's a lot to think about. How do you define your administrative boundaries, for example, and what if information is shared from one administrative boundary within a country to another administrative boundary? What are the rules and procedures around that? How long can the other administrative boundary make use of this information? There's a lot to think about. These policy documents are not computational, but it guides what the semantics and the structural side of your interoperability needs to look like. Because I don't think I'll have time to run through everything here, but I think this is just a quick example of layer 2 of interoperability showing a lack of compliance when it comes to the inappropriate use of a data element. Your first name and given name do not match. Therefore, the LAT system doesn't know what to do with this because it doesn't understand what first name means. It only understands given. We've got semantics. Here we can see a lab system expecting a very specific code from SNOMED, but it's getting this code coming in. Is the server going to reject that? Probably not. It will still accept that, right? It's providing a code. This maybe if your value is mandatory, unless you specifically coded this, when I say coded, sorry, I mean profiled, to say this code must be sent, but not likely. or could be. But the point is that at this particular example, the lab system's expecting this code, it's getting a completely different code. I don't know what to do with this. I'm going to save it, but I'm not going to be able to report on it. And then what we can see here, it's just basically a compliant exchange. We've got a FHIR server. The FHIR server is making sure that what you're sending in, the message coming in, is actually compliant with the FHIR specification. In other words, a correct use of data values and, of course, the data elements. And then we've got a FHIR implementations guide over here, which kind of shows that you can actually extend or add a more specific layer of conformance to your FHIR framework, or to your FHIR exchange, sorry. And that's typically through FHIR implementations guide. And then your FHIR implementations guide, together with the base FHIR framework, provides conformance and validation testing. And then I won't have time to really go to too much of these standards, but there's a couple of standards one could really think about. You've got content standards, which is sitting at interoperability level 2, vocabulary and terminology standards at level 3, transport standards at level 1, you've got privacy and security standards at level 1 and 4, and then, of course, you've got your identifier standards. Guys, I do apologize, but I know time is running tight, so I think I might need to pause there for a second and maybe just hear if there's any questions. Then maybe if there's still time left, I can actually maybe proceed. Otherwise, I'll be happy to share this presentation and then answer any questions that might come out over email or so. But let me pause there for a second. I would like to hand over back to the AeHIN facilitator just for guidance on that. Thank you.
Yes, thank you very much, Sir Richard. So now we're opening the floor for questions. Please feel free to enter your questions if you still have any. And then we'll try to answer them during the session or after the session. In the meantime, let's go through the questions available in the chat. So the first question is from Dr. Daniel Lead. Did you face multilingual code descriptions validation with FHIR, and how could OCL deal with that?
Yeah, thanks. That's a very good question. So right now, we've just recently started engaging with OCL specifically through to support the IPS use case in Sri Lanka. So I can't really say I've had any consider multilingual instances yet, but yeah, I'm not quite sure what to expect, to be honest, until we've really encountered that problem. But right now, it's just been a very straightforward process, very, very basic. Yeah, I've got no experience with that, unfortunately, to really say I've experienced a challenge in that space yet with that use case.
Thank you, Sir Richard. Our next question is from Dr. Alvin Marcelo. Richard, I understand FHIR questionnaire resources are not yet mapped to SDCs.
So please repeat that question.
Yes. Yes, Dr. Alvin.
Yeah, let me do that. Hi, Richard. First of all,
Hello.
congratulations. Thank you for your time, sharing your talents, and also taking the risk of taking that examination for certificate. Congratulations for passing it. It just means it's possible. It's possible. We just need to do the 6 months or more of hard work, and then we have the right people here. We just need to give them the time, and for you also to inspire them that it is possible. They just need to give time and dedicate their resources and mindset to it. I think that's why we invited you, so that the people here will get the inspiration coming from you. Thank you for the slides, very insightful. A lot of people are asking for the slides. I hope you will permit them. My question was really, we when we started our experiments with FHIR, we were like, my group, the UP Manila Standards and Interoperability Lab, started doing FHIR questionnaires. Of course, we were very naive. Our use case was viral hepatitis. And, it was very easy to create the FHIR questionnaire and the FHIR questionnaire responses. And then we just realized that this doesn't really map to anything yet, because they're not yet mapped to the SDC. That was at least about 18 months ago.
Mm-hmm.
That's the point of my question. Would we advise developers, given the mandate or a use case by government, for example, viral hepatitis, to just convert the paper questionnaire forms into FHIR questionnaire resources? Over.
Yeah, thanks very much for the question, Alvin. Yeah, so we've also kind of really been creating some questionnaires for a specific use case. So I guess it depends. So what you want to capture in the use case, because a questionnaire is not very specific and it's not going to map to any resource. If you want to capture very specific information, for example, like for an observation or for an encounter or for some sort of condition, if you use a questionnaire, you're not going to really get those very specific. So you'll probably still need to make use of those FHIR resources, and then actually you can reference it. Then you add a data element, then that makes reference to that particular FHIR resource that actually adds more detailed context to that answer captured in the questionnaire. I think that's probably the best way to go about that, in my opinion. I don't know if that helps, Alvin.
Yeah, that helps, Richard. Thank you. Cha,
Sure.
go ahead. Thank you.
Thank you, Dr. Alvin. Our next question is from Dr. Daniel Rosen. What does a senior ministry decision maker versus a project or program manager versus technical implementer need to know about FHIR?
That's a good question. So that's something we've also been trying to really figure out. So how do you kind of tailor your trainings for a very specific audience? For example, you've got like your FHIR leaders. Who are your FHIR leaders? It's like your program management staff, like directors, for example, directorates. There could be several others as well that really need to be aware of FHIR. So what are the benefits of FHIR? What are the costings of FHIR? What you need to do to implement FHIR at that kind of level? And then you also have like your capacity requirements for more around like your business and technical staff. So that the persons who would actually just kind of document and define what your use case is, then translate that into a FHIR implementations guide describing the compliance framework for your exchange. So that can really depend. And also the way you want to go about providing FHIR knowledge or capacity within your organization can change from one organization to another. A title in one organization is not necessarily going to have the same meaning as the title, the exact same title in another organization. So I guess it also all depends on the need. For me, an implementing partner, again, it depends on the role. What are they going to be expected to do? But in my experience so far with like implementing partners we work with, they all actually understand FHIR. They don't necessarily understand FHIR from a FHIR training point of view, from a very technical FHIR IG profiling point of view, but they just understand FHIR from this is what a payload looks like. This is the requirements from a health information exchange technological point of view. But what we're also trying to do, which one of our key aims is, as we move towards implementation, we create capacity. We're trying to provide guidance, and we're going to train implementing partners where possible, and of course in-country participants or in-country staff, should I say, sorry, on how to actually create these FHIR IG profiling activities or profiles, sorry, and go about that through the various activities. So it can be quite a tricky task, but that is something we're actually trying to really, really focus on. I don't think there's any one such kind of direction, really, I think, just around how to go about that. But I don't know. Yeah, it's just something, but well, we've got some sort of process in place at the moment, which seems to be working quite well. But I guess it all depends on your target audience. I hope that answers.
Thank you, Sir Richard. I think there are no new questions in the chat box yet, but I think Dr. Alvin has a question.
Thank you, Cha. Hi, Richard. In one of
Hi.
your slides, you showed the organizational, the semantic, the syntactic, and the foundational type of tasks or capabilities. And I asked a question in the chat box if there was a RACI matrix, like the organizational is the responsibility of the National Digital Health Officer, and the semantic is the role of, I don't know, standards and interoperability lab, and then the syntactic is the responsibility of HL7 FHIR, something like that, a RACI matrix. And then Wendy responded that she started something and that she's willing to share that to the community. Have you also extended your model into a RACI matrix? And if so, is that something that would be interesting to the group? I'll be very interested. And I mean, we can compare notes and come up with a recommendation and show that to the rest of the AeHIN community. Back to you.
And thank you so much for the question. And the answer is I don't actually have a RACI matrix for that yet. And I was about to say that is actually an excellent suggestion. So thank you to my CDC colleagues for actually pointing out as well that that's also in the process of being defined. And I'll be very willing to support that as well and to define what this looks like. But that's a very great suggestion, actually. But I haven't seen one yet that actually does exist.
Great, Richard. So Richard, Wendy, let's do this. Let's look in the other lab in AeHIN, Dr. Chaminda, Dr. Bunchai from the other countries. Then we can work on this. Thank you, Richard, for presenting that slide, and Wendy for sharing whatever you have right now. Thank you.
Thank you very much.
Thank you, Chris, and thank you to the GEMBI team for taking the risk of taking that examination and passing it, Richard. We hope that all the other interoperability labs in the call and any other AeHIN member would take that opportunity as well when that opportunity becomes available. Good night, everyone. Thank you for joining.
Thanks all.
Thanks for
Bye-bye.
your support, Alvin.
Thank you. Thank you, Chris. Bye.
Thank you.